Well, welcome back for part 2 of the pathophysiological concept map for a diabetic BKA. I just want to take a moment before we dive into this to alert you to the fact that I tend to be a non-linear thinker when I'm doing things of this sort. So if it doesn't all seem to run perfectly in order, that's just the way I think. Hopefully it won't be too confusing. So the first thing I'm going to do is update the color codes and stuff, and we're going to add a box here for the reason the patient's here. He's having a below-the-knee amputation. Now, one of the impacts of that is he's not going to be able to ambulate after he's had that, and he's got a medical history of CHF and hypertension. So, post-surgically, he's going to run a risk for pulmonary edema or even an embolism. So we want to note that and rearrange things a little bit here again. And of course, with an amputation, there's going to be grief, fear, anger, and I'm going to add some current assessments here. I should have added those sooner, but here's the information that I have to work with about this patient. You'll probably note at some point that it should be more complete. But he's got, at the surgical site, he's got drainage, it's reddened, it's painful on palpation, the limb is swollen and edematous. There's drainage that's both copious and serosanguinous. He's got a temperature, his white count is elevated, and he's depressed. So looking back at other vitals, we see that his O2 saturation is not quite what we would love to see. And one of the things we've observed is a change in mental status, and that could well be connected to both his oxygenation as well as his grief and fear. So yeah, he's depressed and withdrawn. So that's one of the elements of our assessment. What do we have here next? Okay, so surgery does damage to tissue, and when you damage tissue, there's consequences to that. So we're going to take a moment here to rearrange the layout as we hook in the cell damage and destruction. And let's see, what else have we got going on here? Oh yeah, we're going to be doing dressing changes. Well, when you do dressing changes and of course the surgery itself, both incorporate a risk for bacterial contamination of the surgical site. He could have an infection, which based on his symptoms, it looks like he may well have. So let's add that in. Post-op infection is a potential problem for this patient. And post-op infection leads back to cell damage and destruction, which causes other problems. So I'm also going to note over here the things that are relevant to that post-op infection. His temp, his elevated white count, the swelling, the edema, the drainage, the condition of the incision. Okay, so we're making progress here. So we hook those all together and again rearrange things a little bit to keep it readable, at least semi-readable. Now we're going to add 3 more things that are relevant to the inflammatory process. You have mast cells, you've got cellular components that are released, and you've got the plasma protein system being activated or potentially activated. And one aspect of these 3 items is that activating any one of them runs the potential of activating the other 2. And we're not going to talk about it today, but that's one of the components of somebody having a sepsis experience. So we're done for the moment, and please come back for part 3, which is waiting in the wings.